You're listening to Fast Facts Perio Edition. And now, here's your host, Katrina Sanders.
Hello, and welcome to Fast Facts Perio Edition. I don't believe it. It is actually here, y'all. We finally have a research data point that is starting to help clarify for us the impact of periodontal classifications on subsequent treatment planning. This research study was done looking at how we can take and integrate, in its simplest form, the 2018 revised classification of periodontal diseases into developing individualized care to meet each patient's needs. This becomes absolutely critical in achieving successful outcomes. Okay. I can't believe it. I'm like losing my mind over here because for so long, we've seen how we classify diseases of the periodontium, and yet we haven't had a lot of clarity around what are some of the appropriate clinical decision-making modalities that we should tether to our patients. So this is going to give you a perio update, as it were, in developing decisions inside of your critical clinical care. I'm going to begin with a short disclaimer. The disclaimer is that everything that I share on Fast Facts Perio Edition is research-based, and the research data point will be included in the show notes for you. At a minimum, it should be the determination of the treating dentist and or the clinical team as to what the appropriate treatment modality is based on our patients. We know that periodontal disease does not show up the same way in all patients based on the speed, progression, rate, extent, severity of the disease process. You may step outside of some of these clinical decision-making modalities because each patient is different. My disclaimer simply shares that based on how we classify disease, there are going to be some treatment recommendations that a clinician should consider integrating in the delivery of optimal patient care. Okay, let's begin. Let's start with gingivitis. Now, gingivitis is a disease of the periodontium, albeit reversible in nature. We know that pocket depth does not necessarily mean that the patient has periodontitis. In this form, an advancement in a gingival pocket could indicate hyperplasia or tissue overgrowth. According to new data points, the treatment for gingivitis is patient education and a debridement. Scaling and root planing is not appropriate care for a gingivitis patient. And in fact, there are studies that show that scaling and root planing in shallow pockets can actually cause an increase of clinical attachment loss. Stage 1 periodontitis, characterized as a pocket depth of 4 millimeters or less, where there is clinical attachment loss. So we are seeing breakage around the cemento-enamel junction of 1 to 2 millimeters. Treatment is usually performed following a non-surgical protocol. So this research data point says here that treatment will usually consist of oral hygiene instruction, oral prophylaxis of pockets 3 millimeters or less, SRP performed in deeper pockets, and a site-by-site re-evaluation according to response time, ideally within about 6 weeks post-treatment, and assuming that the patient has had adequate response to therapy, the patient would then be placed on a periodontal maintenance every 6 months. In a stage 2 periodontitis, characterized as a pocket depth of 5 millimeters or less, and now we're looking at clinical attachment loss or breakage around that CEJ of 3 to 4 millimeters. In a stage 2, treatment can be carried out by a primary practitioner, or the patient can be referred to a periodontist. The decision for a referral, of course, is based on a complexity of the patient's periodontal condition as well as skill level of the practitioner. At stage 2, treatment usually consists of oral hygiene instruction, oral prophylaxis of pockets 3 millimeters or less, SRP performed in 4 millimeter to 5 millimeter periodontal pockets, and then a re-eval at 6 weeks post-treatment. Assuming that response has been adequate, the patient would be placed on a periodontal maintenance schedule that is appropriate for the patient. We know that in many cases, many factors can be responsible for subsequent lack of response. That could be things like inadequate removal of all subgingival calculus, and that is when we're using a blind scaling and root planing approach. We know that sometimes patients will not return to periodontal health at the time of that reevaluation. So if the patient does determine at that reevaluation that they have not fully returned to periodontal health, then these patients should not be placed on periodontal maintenance, but rather active therapy should continue. Looking at some of the causative or etiological factors that may be needed to be managed in these cases. If the patient does display periodontal health, they will be placed on a periodontal maintenance at an appropriate interval with appropriate reevaluation to effectively evaluate activity or progression of the disease process. In stage 3 periodontitis, this is considered an advanced stage of the disease in which typically we will not see a full response to non-surgical treatment. Based on this, initial referral to a periodontist for these advanced care modalities should be considered. Remember, a stage 3 periodontitis case is classified as a probing depth of 6 millimeters or greater and clinical attachment loss of 5 millimeters or greater. This is where a stage 3 treatment will necessitate, almost always, advanced periodontal therapy. This will be a combination of oral hygiene instruction, looking at risk factors as either localized or systemic concerns, scaling and root planing, usually on all teeth with a reevaluation after initial therapy at 6 weeks, then treatment planning for advanced therapy, which might include prosthetic treatment if needed. This is where we might be looking at surgical cases or maybe resculpting of remaining tissue or looking at regenerating lost tissue, as well as then, of course, placing a patient on periodontal maintenance and subsequent reevaluations as necessary. It should be noted that more frequent maintenance visits might be indicated in some situations in order for us to achieve our goal of eventually increasing the amount of time between those maintenance intervals as long as patient response is going to permit this. We recognize that in all cases, if active disease returns or if the progression of the disease is noted, the patient should be returning back to active therapy to essentially control the activity of the disease process. Now we move on to stage 4. Stage 4 is characterized as advanced periodontal tissue degeneration, in which 5 or more teeth have now been lost due to the disease process, and now extensive prosthetic needs are going to be instituted because of bite collapse, masticatory dysfunction, or other factors. This is where we'll see patients with advanced furcation involvements, advanced angular defects, where these teeth are hopeless prognosis. And it should be noted that treatment of a stage 4 case is going to require a full team effort because of that tooth loss, occlusal changes, prosthetic plannings, etc. So now we're looking at other disciplines that might be needed, like ortho, endo, and or a physician consultation. Treatment of stage 4 periodontitis is best performed under the supervision of a periodontist who can aid in coordinating these advanced care modalities. Bottom line, looking at some of these earlier stages, we certainly can be a bit more prudent and subsequently manage and monitor these cases. As we move into advanced stages of the disease process, the complexity of these diseases alone are going to render the patient needing likely co-therapy or multidisciplinary therapy, not just with a periodontist, but in some cases, primary care physician or other specialties. We recognize that if periodontitis is not controlled by the initial treatment that was rendered, that the patient needs to be informed of this, as well as the need for advanced care. The repeated use of basic therapies like a closed or blind SRP that fail to control periodontitis is not going to be adequate or ethical in our patient care. This is where we have the opportunity to critically look at patient-centric care plans that meet the needs of our patients. With that, thank you for joining me. I hope that this episode offered some clarity around clinical decision-making modalities that make sense for you inside of your clinical practice. This has been another episode of Fast Facts, Perio Edition with Katrina Sanders. Please feel free to reach me on Instagram at The Dental Wine Genist or on my website, www.katrinasanders.com. Cheers.